everyone, welcome to our training on restrictive procedures, punishment, and reactive strategies. This is the training for our Florida staff. I'm Tracy. For our agenda today, I'll be covering restrictive procedures and punishment, and Carrie will be covering reactive strategies and Florida Statute 65G8 in detail. And then I'll be back to talk about some additional company policies we have in place to ensure protections for our clients and support for our staff who work with very challenging behavior. We're going to start with restrictive procedures. Restrictive procedures are those that limit a client's access to an environment, limit a client's choices, or limit a client's freedom of movement. Restrictive procedures are just that. They're restrictive in some way for the individual. These are the procedures that are implemented as part of a client's ongoing behavior services, and that is how the team is supposed to respond to challenging behavior. Restrictive procedures are generally not crisis procedures. They're implemented in response to maladaptive behavior to help the client progress towards their goals. An example of a commonly used restrictive procedure is blocking. Blocking might be utilized to prevent the client from hurting themselves, as in the case of self-injury, from hurting others, as in the case of hitting, or from damaging property, such as punching holes in the walls. Blocking is also sometimes used to prevent stim behaviors or sensory behaviors when they pose a concern for the individual. Blocking is a procedure that limits both the client's choice and their freedom of movement, and therefore constitutes a restrictive procedure. Blocking that involves hands on the client for more than 15 seconds becomes a reactive strategy, and Carrie will discuss the details of that a little bit later. Another common procedure is guided compliance. I'd like to distinguish this from errorless learning, where you might guide a client hand over hand, but they're not refusing your assistance. Guiding compliance in plans is generally written so that instead of allowing a client to escape a necessary task, physical guidance is used to ensure task completion. In the case where guided compliance is used when the client is resisting, it's a restrictive procedure. You're not allowing the client freedom of movement, and you're also not allowing them a choice. And a less commonly used example is timeout, but I think it warrants some discussion. Timeout is the involuntary removal of reinforcing activities. In this case, you're restricting their freedom of choice, access to the environment, and their freedom of movement. An important note is that timeout is no longer timeout after 20 minutes of implementation. It becomes seclusion if the procedures are still being implemented and the client has not met their calm criteria. So Carrie's going to be covering that as well. So these are some considerations when you're thinking about recommending restrictive procedures, and also a list of what's required in the client's behavior plan if you do recommend them. So there must be sufficient justification for restrictive procedures to be utilized, and that is the client is engaging in harm to themselves, to others, or significant property damage. This is not tearing up a paper, this is punching holes in the walls. You need to include all attempted and exhausted reinforcement-based procedures. So that might be a table of all of the strategies that have been attempted prior to putting a restrictive procedure in place. We want to make sure that we are starting off with the least restrictive, least intrusive intervention necessary for the client to make progress towards their goals. You'll have to have behavioral criteria for the onset and offset of the procedure. So what is it that the team is looking for in terms of behavior for this procedure to be implemented? There needs to be specific behavioral criteria, like 3 instances of aggression within 20 seconds. And there also needs to be a criteria for the offset. So when are we going to remove the restrictive procedure? So when the client has met a particular calm criteria, maybe. The plan needs to include a detailed fading plan for that specific procedure. So if you have multiple restrictive procedures in the plan, a fading plan is needed for each one of those procedures. And those need to describe how the client is going to progress from the restrictive procedure being utilized to a less restrictive intervention. What are the steps down? How are they going to progress towards that least restrictive intervention? And what are the criteria for the client moving down? There needs to be an enhanced schedule of data analysis to determine whether the procedures that are being used are effective or if they're ineffective. So instead of data being examined monthly or every 2 weeks, however it is in your plan, it would need to happen more frequently if these procedures are in the plan. So maybe a weekly data analysis or every other week to make sure that the client is making progress with these procedures in place. And there also needs to be some kind of criteria for how you're going to determine if the procedure is not effective. So what are you looking for in the data to suggest that there is an improvement or that there's not an improvement and something might need to change in the plan? You need to have notification procedures in place. So as the analyst, you need to be notified of when the procedures are being utilized and if they are meeting certain criteria, when your team is going to contact you and let you know that it's been utilized. Depending on the procedures and how restrictive they are might determine that notification schedule, but you do need to include that in the plan. If you are using a timeout procedure and it progresses to seclusion, you need to have something in the plan related to how you should be notified when it becomes seclusion, that you need to have verbal reapproval at 1 hour if the procedure is still being implemented, and that you need to have eyes on the clients for it to progress past 2 hours. Carrie's going to talk a little bit more about this in relation to seclusion. And then also the informed consent needs to be very detailed. It's important that we list the specific restrictive procedures we have in the plan in the informed consent in understandable language. It's often that caregivers don't read our entire plans because they're 40 pages long sometimes, and having it very clearly outlined in the informed consent. You should be going over the procedure with them, making sure that they understand it. So meeting with them to talk about it, not just sending them a consent form, and really making sure that they understand when the procedure would be used, the justification for the procedure, when you're going to stop using the procedure, and if the name of the specific procedure you're using is not very clear, so maybe you're saying something like their calm procedure, that doesn't really describe what is going to be happening with the client and with the therapist who's implementing the procedure. So if it's a calm procedure that involves hands-on, that needs to be described in the consent itself. Moving on to punishment procedures. Punishment procedures are intended to decrease a behavior. So you are adding something or removing something as a consequence for challenging behavior in an attempt to reduce that behavior over time. Punishments should only be used when it is absolutely necessary. Our position is that we should always attempt reinforcement-based procedures, all available reinforcement-based procedures, and exhaust those before we put punishment procedures in place. And we don't want to have punishment procedures in place with behaviors that aren't severe or pose a threat of harm to the client or others. So we want to make sure that they're only used when they're absolutely needed. Punishment must be used in combination with reinforcement for other more appropriate behavior. So it is not sufficient in the plan to have a procedure that is only punishment based. There must be a reinforcement component that is as great or greater than the punishment component. And just to clarify, positive punishment is where something is added after the behavior occurs. So typically this is a non-preferred consequence intended to reduce the occurrence of behavior. Negative punishment is when something is removed after the behavior. It's typically removal of a preferred activity, and it's intended to reduce the occurrences of behavior. So as with restrictive procedures, we also have considerations for using punishment procedures, and these considerations are also things that need to be documented within the plan itself. So we want to determine, is punishment the least intrusive intervention necessary for the client to make progress towards their goals? We need to have documentation of all reinforcement-based procedures that were attempted prior to recommending punishment. There needs to be sufficient justification in the plan, so behaviors are harmful to the individual, behaviors are harmful to others, there's really significant property damage to warrant the use of punishment. There needs to be fading plan with details on how the procedure will be faded to the least intrusive intervention, like we talked about with restrictive procedures. And there needs to be clear implementation criteria, and that means when punishment should and should not be implemented. So what are the specific behaviors we're looking for when we would implement punishment, and then what are the specific behaviors that we're looking for to stop using punishment. There needs to be an enhanced schedule of data analysis and a criteria for determining the effectiveness or ineffectiveness of the procedure. Punishment procedures also need to be outlined in the informed consent in a descriptive way, an understandable way. It needs to be reviewed with the caregivers and make sure that everybody understands what will happen with the client when they give their consent for these procedures. All right, moving on to reactive strategies. I'm going to turn it over to Carrie here in just a minute. I want to go over sort of the basics of what reactive strategies are and what is 65G8 you've been hearing about. So 65G8 is a Florida administrative code, and it basically says reactive strategies are the procedures or physical crisis management techniques of seclusion or manual, mechanical, or chemical restraint utilized for control of behaviors that create an emergency or crisis situation. So they're only procedures that are used when crisis happens, not as part of the client's ongoing behavior intervention that the whole team is implementing every time you see them. So the 65G8 rules indicate that reactive strategies protect clients from unnecessary restraint and seclusion when they're implemented, requires training, prevents the use of reactive strategies when it's not medically safe, and identifies who can authorize them, limits or prohibits certain procedures, and requires documentation and reporting. Clients have a right to be free from unnecessary restraint and seclusion. Restraint should only be used in an emergency. It should only be used to protect the client and or others. It may not be used as a punishment or for the convenience of staff, and it may not be used as a substitute for planned treatment. Reactive strategies should impose the least possible restriction required. They should be removed when the emergency ends, should not cause physical injury to the client, and should be designed for the greatest possible comfort. And I'll turn it over to Carrie to describe reactive strategies in more detail. She'll be mostly focused on adult clients receiving services through Medicaid waiver. However, we follow the same 65G requirements for all of our clients. The local review committee or LRC requirement she'll describe is only for our adult clients or any other clients who are receiving services through the waiver, such as those in residential settings. I will review our internal clinical review related reactive strategies for all other clients.
We use it during times of an emergency or a crisis situation, and it is required that if we're implementing these on a regular basis, that there has to be an LRC approved behavior plan that indicates how and when to use them. So your residential settings, yourself, other APD providers can use a reactive strategy without, or manual restraint, seclusion without behavior plans, but they then have to request behavior services for those individuals. So these are the ones we're going to go over today in detail. Go ahead. Those of you, I know some of you are on here, you guys actually don't provide waiver funded behavior services, but you provide or have in the past provided services to individuals whose behavior services are funded through Medicaid. APD has indicated that any person who provides services to an individual who receives any type of service through APD, so maybe they live in a residential home, but their behavior services are provided through Medicaid. Maybe they live in a family home, you bill Medicaid, but they receive personal support through APD or the waiver, they require us to follow the 65G8 statute. Okay, go ahead. So we're going to go over each of these in detail, starting with manual restraint or physical restraint, which most of us are, you can go ahead, are using PCM or trained in PCM. That seems to be a common one throughout our area, although there are others, safety care team, seem to be a couple of other common ones. By definition, in the Florida statute, according to APD, the use of your hands or your body to immobilize a person's freedom of movement or access to their body for more than 15 seconds. So this could include a response block. So you have somebody who injures, who has self-injury, maybe they are, hitting themselves in the face. You use your hands to prompt their hands down. If you have to hold their hands down for more than 15 seconds, that is considered a reactive strategy. Obviously, any type of vertical or horizontal immobilization, on a mat or holding a person would be considered a reactive strategy. All reactive strategies have to be reported to APD on a monthly basis. So if you're using them, if an APD provider is using them, they are responsible for reporting this every month. APD does look at how many are used, how long they're used, and they're ensuring that everyone has the proper training and certification to do so. If you need to guide somebody, transport them, have them walk with you, if you have any type of hands-on individual that lasts for longer than 2 minutes, that also has to be reported. It is now considered a reactive strategy. A lot of times people think that reactive strategies are not a good thing, and they try to circumvent the 15-second or 2-minute rule. There's nothing wrong with implementing a reactive strategy. It just has to be reported. It has to be done properly and reported to APD on a monthly basis. So people will, put hands on. I've seen people let go because they know the 15 seconds is coming up, even though they know the individual might strike themselves again. It's not ethical, it's not safe, and it's not what we want to do. So it's something that we need to train staff on and then be aware of when you're working with individuals. If you're using any type of manual restraint, as I said, you have to use an APD approved curriculum, but you also have to be trained and certified. Most of them require you to be recertified each year. So if your certification or if it ends, you are not able to use this. When we're implementing manual restraint, so if we have somebody in some type of hold or immobilized, when we get to that 1 hour mark, it requires approval. So anybody who's trained and certified can implement the manual restraint, sorry. But once it's been 1 hour, it has to be reapproved by whoever it was that initiated that restraint. For manual restraint, it can be anyone trained in that curriculum. It does not have to be a behavior analyst. I know many of us in the field kind of believe that best practice is that when you hit that 1 hour mark, whoever it is that's implementing that procedure should notify you as the analyst that your client you're working with has been in a restraint for 1 hour. So we typically will write that into behavior plans. If you are doing or you're writing manual restraint into any behavior plan, there has to be a physician sign off. And we have that as part of our intake file for, I think, all of our individuals. But group home or residential settings do this as a part of their annual process also. It has to be done every year. There have been APD individuals who have died in manual restraint. So we need to make sure that the physician signs off and that there are not any pre-existing conditions that would make manual restraint, contraindicated for that individual. So individuals with Down syndrome frequently have limitations on the restraint they can use. If there's a heart condition, obesity, all of those could be reasons why a doctor may not sign off on all procedures of restraint because it is a health risk to them. Okay, next slide. Timeout. So we tend to think of timeout as just being timeout as reinforcement. APD has their own, or the Florida statute kind of defines timeout somewhat differently. It's an involuntary isolation of the person, or involuntary removing of the reinforcement. So it can be done in a person's bedroom. It can be done in a timeout room. It could be something as simple as saying your client has to sit in a chair or they have to sit on the mat. Even though you're not putting hands on, you're requiring them to stay in that position. You're not allowing them to come and go and do what it is that they want. If they get up and leave, you're going to, require them to return to that setting. This is considered timeout according to the Florida statute. Timeout can be used in a behavior plan that is LRC approved. If it's used without a behavior plan procedure, it's considered seclusion. Seclusion is considered a reactive strategy that requires more, and we're going to go into that in a minute. It's important to remember anytime you're using timeout, especially if it goes on into seclusion, that you are maintaining that line of sight of supervision, or the staff is maintaining line of sight supervision. You obviously don't want to be making eye contact, because if you don't want to, be providing that level of attention to the individual in the timeout setting, but you have to maintain supervision so that you're ensuring their safety. You're ensuring, that they're not getting into, grabbing something in the area that could harm themselves or others, or that there's no medical issue. So it's important when you are using timeout that you're training your staff that they cannot leave somebody alone. Go ahead. Like I said, if you're implementing it in an LRC approved behavior plan, it's just considered timeout. However, when that timeout lasts longer than 20 minutes, so your person is not meeting their calm criteria, they have not calmed down enough to allow them to get up and go about their day, it is then considered seclusion by the Florida statute 65G8. If you're implementing timeout without an LRC approved behavior plan, it's also considered seclusion. Any type of seclusion must be documented and reported to APD, which is the important reason for knowing the difference between timeout and seclusion. Timeout does not have to be reported to APD. It's important for you as an analyst, keep track of that data because it is important for receiving funding or maintaining funding, but it doesn't have to be reported monthly. Go ahead, Tracy. Any person who, in order to implement seclusion, the person must have a bachelor's degree and they must have 2 years experience serving individuals with developmental disabilities. So group home managers usually meet that definition, but not all direct care staff can. So if you have an individual whose timeout is approaching 20 minutes, so you now have them, isolated or confined for 20 minutes, a text to you, a text to the group home manager, a phone call, those things are all sufficient to authorize the seclusion. But you have to then reauthorize every hour or 59 minutes thereafter. And visual observation must occur if your person's in seclusion for longer than 2 hours. Again, best practice is that you, as the analyst, if you're approaching that 2-hour mark, that you get there or have someone get there for you to put eyes on to figure out what's going on. Obviously, your client is in crisis at that point. If they've been secluded for 2 hours and are not calming, there may be something more that needs to be done. It's not required, just best practice. Okay, Tracy. I think I've said all of this. Are there any questions on the difference between timeout and seclusion? Okay, perfect. Next slide. Okay, so important things to remember whenever you're using timeout or seclusion. Your behavior plan needs to indicate that staff should sweep the room, or look through the room, clear it of any objects that may be considered a danger to them. You can never lock the door. So if it's a door and it has a lock on it, you cannot lock that door to keep the individual in there. It can be held shut. You can use a magnetic lock that requires the staff person to hold the lock. As long as when the staff walks away, the door unlocks and the person can leave if they chose to, those are okay according to 65G8. We oftentimes will use the PCM mat and put it in the doorway to serve as a barrier. You must maintain line of sight. So if your door doesn't have a window in it, you can't close the door. So important things to remember. It must have proper ventilation. There's not many timeout rooms in our area anymore. There are still some facilities that use them, but they do have to meet criteria. So we're often doing these in timeout or seclusions in rooms that need to be swept for their safety. So, okay, next slide. You must have calm criteria in your behavior plan. So you as an analyst need to indicate what staff should be looking for and then what they should do to release the individual from the timeout or seclusion procedure. Calm criteria is going to look different for each person. Frequently they're not engaging in any type of maladaptive behavior. Maybe they're crying, maybe for that person they shouldn't be crying. A lot of times we'll do a compliance task to ensure that they're calm. And then what should the staff do when they let them go? Prompt them into a task. Is it just back about normal business? All of that should be included in your behavior plan. Those are things that are looked at by LRC when you submit for approval. So anytime the room becomes unsafe, we see individuals rip things off of walls. We see them break glass, whatever it might be, you have to break time out. Also, if they start to injure themselves or there's some type of medical emergency, you would have to break time out in order to ensure their safety. So, all right, next slide. Okay, chemical restraint. This is not one that is used as frequently in the area. There's a lot of procedures that are required to use it, which make it difficult to use. But chemical restraint is considered it's the use of medication in order to have an immediate effect or control of behavior. So you have an individual, they're escalating, they're meeting crisis, somebody wants, provides them with an Ativan, Xanax, Haldol, whatever it might be, in order to calm them. It's not their day-to-day medication that they take. It is something that we add in addition because they are in a crisis state. That is considered chemical restraint. This has to be included in a behavior plan. It cannot be used in any type of residential or facility under APD. The exception is in a family home. A parent or guardian in a family home is able to use medication as a PRN to control behavior. You as an analyst should be training them and giving them criteria on how and when to use that, but they're not under the 65G8 statute. Okay, next slide. In order to use chemical restraint, a physician, a doctor must authorize it. That doctor must be on site or must be on the phone with somebody who is on site and can see the behavior and describe to the doctor what's going on. The medication must then be administered by a licensed medical professional. This is why it's typically not used in group home or other facilities within our area, because most of our group homes don't have nurses or licensed medical professionals on site. The few homes that do, I know some of them do use chemical restraints. And the criteria for being able to do that is that it is in a behavior plan. The phone call has to be made to the doctor. The order must be dictated. The doctor or whoever administers must have a face-to-face evaluation within 1 hour in order to document whether or not the medication was effective. There are, and I've experienced this, group homes do try to use chemical restraints, not understanding the 65G8 statute. So it is something that is important for you if you're working in some type of facility or group home setting, that you ensure is not something that's being used. There should not be, go ahead, Tracy. You cannot have a script for a PRN on the MAR. It has to be something that is called in. Then they should not, and there's some question on whether or not you can use the medication that's already in the home, and APD is working on clearing that up. So if you ever do use chemical restraint, you just want to make sure that you have the details in the behavior plan so it can be approved by LRC. So, all right, next slide. All right, mechanical restraint. These are used with some frequency in within the area. Mechanical restraint is a device used to restrict an individual's movement or their normal function. So I've given some examples there: a mat wrap, a wrist or ankle posy, a restraint vest. A couple of examples that I've seen recently within the field are individuals in wheelchairs. They engage in either self-injury or aggression to others. So I've seen ankle restraints where the individual's leg is restrained to their chair so that they cannot engage in kicking, maybe during like a feed or a change, a diaper change. Those are considered mechanical restraints. Okay, it's a positioning device, if it's just part of their wheelchair, such as like a chest strap to keep them in the wheelchair, those are not, they don't fall under the statute. Those are, there are no requirements on using those other than what the medical requirements are. We also have individuals who, in the van, they often use harnesses. If a harness is used for a safety purpose, because the individual gets up and moves around the van or attempts to open the door, such as, those are not considered mechanical restraints. We do have individuals who are restrained in during transportation on vans because of behavior, because of the risk that they pose to others. It is then considered a mechanical restraint. Again, there's nothing wrong with using mechanical restraint. You just have to follow the 65G8 statute. It has to be in a behavior plan. Only an analyst can authorize the use of mechanical restraints as they write it in the behavior plan. You have to document what time the restraint goes on, and you have to document what time the restraint is removed. Go ahead, Tracy. The restraint must be removed for at least 10 minutes out of every hour. And that's an important thing that must be in your behavior plan that staff must be trained on. We can't just keep them in restraints for hours on end. They must be able to move their body around. Again, it requires a visual inspection every 2 hours. And best practice is for you as the analyst be there, okay, to see what's going on. Why is it that the person is in this mechanical restraint for so long? We also have an individual in the area who wears wrist posies. So his wrists are tied to his waist anytime that he's in the community because of the risk that he poses to individuals in the community around him. So that would be a mechanical restraint. Okay, next slide. So mechanical restraints and behavior protective equipment are often confused. Behavior protective equipment interferes with or prevents a behavior from occurring. This would be your posy mitts. So you have something on someone's hands to prevent them from engaging in a behavior, from hurting themselves. Maybe they wear a helmet because they harm themselves. This equipment is usually placed on the individual because the behavior is occurring, or can be also used to prevent it in general. I know an individual who ripped her hair out of her head, and she was wearing posy mitts in order to prevent that because she literally, pulled the scalp off of her when she pulled the hair out. So we used mitts then. Again, nothing wrong with using protective equipment. It just has to be done under the guidance of a BCBA. All right, it must be part of a plan. It must be approved by the LRC. Again, the individual has to have an opportunity for movement at least 10 minutes of every hour. You're going to record when they go on and when they go off. There are individuals who are in posy mitts or glove type things continuously because of their behavior. Again, it's okay to do so as long as there's a plan to attempt to fade, and it has to be recorded to APD on a monthly basis. If you have an individual who wears gloves, say they hand mouth, the gloves are fingerless, so they can still do their day-to-day functioning. They can pick things up, they can feed themselves, they can use their hands how they wish. That would not be considered protective equipment. All right. It's only if it interferes with their ability to complete their daily functions. We also use protective equipment sometimes during medical situations. You have an individual who has stitches, maybe they've broken their hand or their leg, and maybe they have a port if they're going through chemotherapy. We will sometimes use mitts in those situations to prevent them from accessing the stitches or ripping the port out of their skin. Those are not considered protective equipment because they're being used for medical reasons. You just requires a script from the physician to use those. Criteria would be that it ends whenever the medical procedure ends. Okay. All right, next slide. All right, sometimes our individuals require law enforcement involvement, Baker Act, or admission into the psychiatric facilities. This is considered a reactive strategy under 65G8. It has to be reported. It happens. Just know it's under 65G8. It must be reported. All right, next slide. As I mentioned, physician sign-off has to be on file for every individual, and it must be updated annually. All right. If there are procedures that cannot be used, it should be noted in the behavior plan. Staff should be trained. You don't want somebody dying because staff implemented procedures incorrectly or when they shouldn't have. Unfortunately, it's happened, but it's our job to try to make sure that we prevent that. Okay, next slide. Okay, all reactive strategies, just as a recap. Got to have a reason to use them. They should be part of a behavior plan. There should be criteria for when to implement them and when to end the reactive strategy. It should be not used as a punishment. We should be doing other things first, least restrictive, providing no pain, greatest comfort to our individuals. Next. Just some things, obviously, hopefully we all are aware we shouldn't be we shouldn't be doing things that are inflicting pain, impairs their breathing. Hands cannot be behind the back. Can't pull elbows up, no elbow control. It loses their balance, covering their face, or again, using something that's not okay with the doctor. Next slide. All right, as I mentioned, all of these have to be reported to APD every month. If you are implementing reactive strategies on your client in whatever setting, it's your responsibility to report that to APD monthly. There is a form on the APD website that allows you to record information and report it. If it's in a group home setting, an ADT setting, the staff that are implementing are responsible for recording and reporting that monthly. You as the analyst should be getting that information, and you should be graphing it on a monthly basis. It's important for funding purposes for your clients. it's important that you know that your behavior plan is working. Ideally, reactive strategies go down with the success of our behavior plans.
Okay, so now we're going to cover some agency-specific policies and protections for our clients and support for our staff working with clients with very challenging behaviors. The first is about quiet rooms. Quiet rooms are spaces and facilities that are generally devoid of furniture or therapy materials. They might have mats or protective padding to ensure client safety, and they're generally not used for therapy sessions. In any location where ABA Solutions maintains a quiet room, so for example in our clinics, or if we utilize a facility quiet room, so for example in the schools we work in, the quiet room must be utilized in accordance with 65G8. There must be sufficient space to stand and lay down comfortably and sufficient lighting and ventilation. We want to make sure that we maximize our clients' comfort when they do need to have procedures implemented in a quiet room. If the quiet room is to be used for any type of involuntary isolation, such as timeout or seclusion, staff must be able to continuously observe the client, monitor their respiration rate, and determine when the release criteria have been met. The door may not be locked. If there is a door, it can be held shut. If there is a window that allows you to continuously observe the client, but the door must be able to be opened by the client if the staff were to step away. It cannot be locked. The client must also be allowed to leave when the release criteria have been met. Timeout and seclusion can only be used on a plan approved by the clinical supervisor and with oversight by the area or site director. It must be implemented in response to a specific behavior defined in the person's behavior plan. If timeout lasts for 20 minutes, it becomes seclusion. Seclusion must be authorized by the behavior analyst in charge of the case. So the staff member must get in contact with the lead analyst and request permission to continue the procedure. And then reapproval must be obtained at 1 hour and a visual observation required by the analyst in charge of the case or the director for the procedure if it continues beyond 2 hours. Quiet room policies must be posted near the door and a data collection sheet should be present. So if you don't see those, please ask the director where those are so that you can collect data. Data need to be collected for every reactive strategy implemented. So every manual restraint, every seclusion, transportation procedures that meet the criteria lasting 2 minutes or more, blocking that involves 15 or more seconds of hands-on time. Those all need to be documented every time. And those data that are collected need to be reviewed by the director at a minimum of every billing cycle. For all non-APD clients, plans recommending the use of restrictive procedures, punishment, or reactive strategies are required to be submitted for clinical review to ensure that all the requirements outlined in the policy are met. This is a protection for our clients, and it's also a way to open up the conversation between analysts, directors, and clinical supervisors to make sure that our analysts have enough support when they're working with challenging behaviors. Plans need to be submitted to the clinical supervisor for review prior to submission to the funder for the initial authorization and prior to each subsequent reauthorization request. Plans should be submitted at least 3 business days prior to the due date indicated by the office on the assessment reminder email. This is the review rubric that will be used to evaluate plans with these procedures. There are 6 items that mirror what's in the policy, including providing justification and exhausting reinforcement-based procedures, behavioral criteria, detailed feeding plans, determining effectiveness or ineffectiveness, notification procedures, and informed consent. We want to ensure that all of the plans are meeting these standards. You can find the review rubric in the staff portal so that you can self-evaluate prior to submitting your plan. The last piece is director oversight. Analysts, you should be communicating with your directors monthly for clients who have restrictive procedures, punishment, or reactive strategies in their plans. This can include reviewing the client's data, reviewing procedures and proficiency data, asking for any support that you need or anything you need to help your client, asking questions, and freely sharing any concerns you have about the case. It's important for our clients that communication is between the clinical supervisors, directors, and the analysts, and it's open, and we can really talk about the procedures that are necessary to help our clients succeed. For RBTs, I would encourage you to check in with your analyst on the case regularly about the client's progress and the implementation of the procedures. It's okay to ask why a specific procedure is used. Analysts are expected to train you, and that involves training on why a procedure is clinically indicated. You should be able to understand the rationale for why the analyst chose to use that procedure, any of the specific criteria, anything that you need more information on, I would encourage you to ask. It's good to have a conversation about that. And then if you have concerns about procedures that are being used, I would encourage you to please voice those to the analyst on the case. Let them know if you're uncomfortable implementing a procedure, if you don't understand why a procedure needs to happen, and if you need more information or you need another person to talk to, I would encourage you to reach out to the director as well. Okay, everyone, that's all we have for you today. Thank you so much for attending. We appreciate you, and let us know if you have any questions. Thank you.